Lisa, please. Okay, so today Dr. Wojciech Vana will speak about OCT and the help of OCT analysis for vulnerable plaques. So Wojciech, please.
So welcome everyone. It's a pleasure to talk with you today about vulnerable plaque and the analysis with OCT. So as we generally know that myocardial infarction is the world leading cause of death. However, on the other hand, we should also know that the ruptured previously vulnerable plaque is the leading cause of the myocardial infarction. So let's start the presentation with the case report with patient with vulnerable plaque. Here you see the 60-year-old diabetic woman which was admitted to the hospital because of the atypical angina. And immediately patient had performed the invasive strategy. So the patient had performed the angio, which showed only 30% of the stenosis in the middle of LAD, as you see over here. The FFR has been performed, which showed that there's not significant stenosis. FFR was more than 0.8. However, the same patient was admitted to the hospital 3 months later because of the ST segment elevation myocardial infarction of the anterior wall, and the OCT has been performed. And the occlusion of that vessel of the LAD was at the same level that was 3 months before in the mild level of the LAD. And what was the cause of those occlusion? The cause of those occlusion was the plaque rupture, because in the mild of LAD was the vulnerable plaque. So what kind of devices do we have to assess vulnerable plaque? We have IVUS, mirrors, we have also alone IVUS, and we have also the OCT. However, among the currently available intracoronary imaging modalities, OCT has the highest resolution and allows imaging of the vessel wall to be closest to the histopathological examination with almost microscopic precision. Moreover, the high-resolution imaging of OCT allow identification of the morphology of the atherosclerotic plaque. However, what is also important that in OCT we can find several features of the vulnerable plaque, and also even before the erosion rupture occurs. So what we can find using OCT as the vulnerable plaque in our arteries? We can find the lipid-rich necrotic core. We can find the thin fibrous cap. Moreover, we can find the microcalcifications. We can find neovascularization, and we can find macrophage infiltration, which are the surrogate of the inflammation. So let's start to talk about the lipid-rich plaque in OCT. Usually it is quite easy to detect lipid-rich plaque using the OCT, and how can we identify that? The lipid plaque is in OCT is characterized by diffuse edge, as you see here in those images, in the left, middle, and the right part of those presentation. We have the diffuse edge with high signal or reflection and high signal of attenuation. But also important to detect the lipid-rich plaque is that the source of the signal change is located in the wall, not in the lumen as it is when we have the thrombus in the vessel. Other vulnerable plaque, quite characteristics when we use the OCT, is the thin fibrous cap atheroma. Usually it's called TICFA. And now we can say that OCT is the gold standard to detect TICFA. How to recognize TICFA in OCT? The globally accepted definition of TICFA is the lipid-rich plaque, which is covered with fibrous cap. However, those fibrous cap should be less than 65 micrometers thick. And going deeply to the TICFA, as you see here in the left part of the slide, there's lipid-rich plaque over here, and to detect TICFA, to define TICFA, those lipid-rich plaque should extend more than 90 degrees in the vessel circumference, and those.
Yeah. Wojciech, in this image, actually, I would have said that the thin cap fibroatheroma is below at around between 5 to 6 clockwise, not in the upper part. I would have said there.
the TIGFA is over here, and we have the lipid, the plaque over here.
Yeah.
So it's more than 90,
Yeah, but
90.
I would say that it is thinner in the below between 5 and 6.
Between 5 and 6. It is
Yeah, between just at 6, I would say at 6. No?
over here.
Yeah.
That it's not that it's thinner, or that is not
Thinner.
thinner.
Thin.
So
Thin.
so okay.
The more the more prone to rupture.
It's so, or yeah, so as you said, so but we have TIGFA like here. However, in that part is thinner. And what is also important that in some papers, some studies, the TIGFA is not 65 micrometers fixed. However, sometimes it's 75. But according to the globally accepted definition, it is 65. But sometimes we can find in papers that it is 75. Later, I will talk about that in the when I present the trials. All right. So can you go? Can I go?
Yeah. Please, just a comment.
All right. There has been many studies which assess TIGFA in the coronary artery disease. However, right now I will show you this is the study which I'm presenting right now, the localization of TIGFA in the culprit lesion in patients with STEMI. As you see here in those presentations, usually TIGFA is located in the proximal part of the vessels. In the LAD is in the proximal part, in the first 30 millimeters of the vessel. However, in right coronary artery is also in the mostly in proximal part. However, it is also the peak in the distal part of the vessel. In the circumflex, TIGFA usually in stem is located also in the proximal part of the vessel, in the first, we can say 50 millimeters of the artery. So usually TIGFA is in patient with STEMI is located in a proximal part of the arteries. However, let's talk about the location on TIGFA with non-culprit lesion in STEMI. So here we have the results from the complete OCT study, which also assess patients with TIGFA. However, in the location where there was no culprit lesion. And the results from those studies show that obstructive non-culprit lesions are more likely to be TIGFA. In that study, non-culprit lesions were categorized as obstructive, so significant that more than 70% of the stenosis. And in that study, the TIGFA was defined as the lesion with mean fibrous cap thickness less than 65 micrometers, overlying a lipid arch more than 90 degrees. So general definition on TIGFA. And in obstructive non-culprit lesions are more likely to be TIGFA. But what also it is important that nearly 50% of patients with obstructive non-culprit lesion have TIGFA. The other important study which assessed TIGFA in non-culprit lesion has been performed by Kubo in the Japanese population, which assessed more than 1,000 patients. As you see here, the authors compared three types of the vulnerable plaques: lipid-rich plaque, which has been defined lipid-rich plaque, which was defined as lipid plaque with maximum lipid arc more than 180 degrees, so more than it is usually in TIGFA. Other group was standard TIGFA, and third group was lipid-rich plaque was TIGFA. And what the results from those studies show? The results from those studies show that patients who had TIGFA, in compared to patients who did not have TIGFA, had 10 times higher rates of the acute coronary syndrome during the long-term follow-up. The median follow-up in that study was 6 years. However, the most dangerous type of the vulnerable plaque are patients when we have lipid-rich plaque plus TIGFA. And that study showed that connection, lipid-rich plaque with TIGFA, in compared to patients we did not have lipid-rich plaque and TIGFA, had nearly 20 times higher rate of adverse events during the follow-up, and adverse events in those study has been defined as acute coronary syndrome. However, the sub-study of those studies showed that OCT parameters of lipid-rich plaque that develop acute coronary syndrome during the long-term follow-up, so in those studies 6 years median follow-ups, were the maximum lipid arc, minimum fibrous cap thickness, and minimum lumen area. The other study, quite interesting study, the combined FFR OCT study, which also our university, our department play a role in that presentation, in that study. The study has been presented by Edwin Keddy and published in 2021 in European Heart Journal. That study, combined FFR OCT study, assessed patients with diabetes mellitus, with patients who had patients who had coronary artery disease in angio more than 40% stenosis, however, less than 80% stenosis. The patients were differed that more than the significant stenosis was assessed as a FFR less than 0.8, and that patient did not play a role in that study. However, the patients would play a role in those studies, so were included in those studies, so were the patient with FFR more than 0.8, so non-significant stenosis in coronary artery disease, however, with diabetes. And what studies show? The study showed that with patients who did not have significant stenosis according to FFR, there was 25% of those patients had TIGFA, and TIGFA was related for a 5-fold higher rate of adverse events despite of adverse of ischemia. So when we look at that study, we know that patients with diabetes without significant stenosis according to FFR, 25% of those patients will have TIGFA, and they have higher rate of adverse events in compared to patients who did not have TIGFA. The other feature of the vulnerable plaque in OCT are intraplaque and neovascularization. How can we identify intraplaque and neovascularization in OCT? We see the black holes, as you see here in the image, the black holes with the diameter of 50 to 100 micrometers that are present for at least 3 to 4 consecutive frames in the pullback images. Here you see the neovascularization. And why neovascularization are quite important to detect in OCT? Because the presence of intraplaque microvessels is associated with higher rates of long-term adverse events. And when we will decide to perform the PCI with stent or with DCB, there is in the area where are the intraplaque microvessels, there is the higher risk of no reflow after PCI according to that data. The other important features of the vulnerable plaque are macrophages. Macrophages accumulation in OCT is defined as bright spots, as you see over here, the bright spots with the high reflectivity and irregular shadowing. And here you see the results from the CLIMA study, which has been prepared by Francesco Prati, published in 2020. And the results from those studies show that the presence of macrophages is associated with an increased rate of adverse events during the 1 year of the follow-up. And in that manuscript has been presented 2 interesting cases with coronary artery disease. In the upper part of those presentations, you see patients with fibrous cap thickness nearly 60 micrometers, lipid arc nearly 200, large MLA. However, there were no macrophages, and during the 1 year follow-ups, there were no adverse events. In the lower part and in of those presentation, you see quite different patients with a fibrous cap thickness thinner than was above, because we have over here, we have 50 micrometers, lipid arc more than 200, MLA 2.6. However, the macrophages are presented, and during the 1 year follow-up, there was adverse events. There was acute coronary syndrome, which was not in patients who did not have macrophages detected in the OCT. The other also important features in the OCT are the calcified nodules. Calcified nodules in OCT are appreciated as intraluminal protrusion or calcified components, as you see over here, with or without the disruption of the intimal fibrous layer. And beside on the histology data, usually they are located in the right coronary artery disease. In the left part of the slide, you see calcified noodle without a fibrous layer disruption over here. However, in the right part, you see calcified noodle with fibrous layer disruption plus thrombus. Here you see the thrombus.
There is the entity of the vulnerable calcified nodules, which is called eruptive calcified nodules, which is a new entity in interventional cardiology.
Yes. And according to the sub-analysis of the CLIMA registry, the presence of the calcified nodules disruption with a high, those calcified nodules are associated with higher rates of 1 year adverse events, such as cardiac death or target lesion myocardial infarction. The OCT is not only tool to perform or to help to perform the PCI. It is also an important tool to assess patients with MINOCA, to find and to understand the lesion in patients with MINOCA, and to understand where is the target lesion, and target vessel which is responsible for myocardial infarction. So this is quite an important point to assess patients with MINOCA. So what can we find in patients with MINOCA when we have the non-obstructive coronary artery disease? So we can find plaque rupture or plaque erosion in that vessel, and according to that presentation, and according to MINOCA and that algorithm, it is here you see the quite interesting study presented by Maximilian Oporski, which published the mechanism of myocardial infarction in patients with non-obstructive coronary artery disease, so mechanism in patients with MINOCA. And the non-obstructive coronary disease has been assessed by a bad cardiac magnetic resonance. And the infarct-related artery was identified by the localization of ischemic type of cardiac resonance with late gadolinium enhancement. And what did they find in patients in non-obstructive coronary arteries disease in patients with MINOCA? So in patients in lesions which were responsible for myocardial infarction, so infarct-related artery, in compared to lesions which were not diagnosed as infarct-related artery. So those lesions had quite higher rate or significantly higher rate of plaque disruption, thrombus, plaque disruption and thrombus, and TICFA. So that kind of vulnerable plaque has been found in the OCT, and they were much more often in infarct-related artery in compared to lesions which were now responsible for infarct or for myocardial infarction. So in conclusion, I would say that the current understanding of the mechanism of acute coronary syndrome is mainly driven by the pathology studies. And intracoronary imaging modalities will broaden the current knowledge on the plaque vulnerability and have the potential to identify patients with more aggressive atherosclerosis and high risk of cardiac events in such patients. However, it is still unclear how to treat patients with vulnerable plaques in secondary prevention. Thank you for your attention.
Thank you, Wojciech, for this nice and timely presentation. You discovered very interesting papers on the topic. Those from Francesco Prati and Opolsky are important trials that underline the importance of OCT for understanding the presence of vulnerable plaque. And this is the good part. The good part is also, as you show in your first slide, that in many cases we do physiology. Physiology is useful. Many studies have shown how in intermediate lesions physiology is useful to predict the outcome, but it cannot predict the plaque that is going to evolve because it's vulnerable or it's evolving plaque. Because some plaques, like in the cases that you have shown, can very, very fastly grow and lead to myocardial infarction or adverse events. The problem with imaging, especially with OCT, is to understand what to do when we face a vulnerable plaque. Because if we do OCT and we find a vulnerable plaque with a small MLA, it's easy to give the indication for angioplasty and put a stent. On the other hand, if we have a vulnerable plaque with a large lumen, it is not well understood yet what to do. Because if we put a stent always trying to fix the plaque behind the signs of vulnerability, we don't know if we would encounter in a higher late occurring events related to the PCI that we are doing. So to me, this is not very clear what to do in many cases. What do you think? I don't know if you have a comment on this, you or anybody else.
There's a big discussion how to treat those kind of patients. I think till now we don't know. We can only expect that when is the significant stenosis we should stand, and we don't know what to do when there is not significant stenosis according to the FFR measurement. And I think that in next years we could have the answer, because there is also the combined interview study which is ongoing. They compare the two groups to stand or not to stand. However, for me, it is quite interesting. The DCB are safe in patients when we have vulnerable plaque, when we have TICFA and significant stenosis. And
yes, this is an important topic. We only have one single prospective registry which has been presented at TCT. I've not seen the publication yet. TCT last year, 2 months ago, and it's shown that it has shown it in small numbers that paclitaxel DCB is safe in this setting. But I think that theoretically DCB is good, but we need more data. Maybe a large study with an optimal medical therapy in both arms, DCB versus only therapy, could be the answer. But we need a clinical endpoint in such a study, because only showing that DCB is able to fix the plaque, okay, this is interesting, this is important to us, but it's not enough to in my opinion, to warrant a therapy with DCB in all of the vulnerable plaques that we find. But it's still a work in progress. I think that it will take a few years before having definite answers on this. But this is the beauty of our job, to have new questions arising after interesting studies like the ones that you have just shown.
Because later on we could have TICFA when we implant the stent. There will be atherosclerosis in the ears, and again TICFA.
Yeah. Yeah,
so
and we know that the stents are occluding. That's a problem. So this is why it's not advisable to put a stent if the plaque, if you don't have a thrombus and if you have a large lumen. with a thin cap fibroatheroma. Alessandra, Sarah, Jacinth, I've seen also Krupal and Antoine have joined us. Do you have questions or comments?
No, just an information. Maybe I missed one. The Japanese study about thin cap fibroatheroma. How long was the follow-up? Because I'm impressed. Sorry?
Presented by Kubo. Takash Kubo. It
I
was,
think so.
Was 6 years. The median follow-up was 6 years.
Okay, fine. Because I'm impressed that in the study by Prati, they need only 1 year to demonstrate.
1 year.
Exactly, only one to demonstrate a different rate of events at follow-up. Just for
yeah, but the population
macrophage.
was quite large in the CLIMA study.
I don't remember.
Oh, I don't remember. How
the
many
number?
patients?
95 patients, I think. Not
no, in CLIMA, no, the big study.
I think 1,000. No,
1,200 if I remember well. 1,200. But you can check it.
But they were comparable, I think. So this is why it's really important to find what to do in these patients, even with the normal MLA, because in 1 year they demonstrated a different rate of events.
Yeah.
In climate study, 1,003 patients.
1,000.
So
yeah.
1,000, but not so
study.
many. So big,
yeah,
but
not. The Japanese study is a mechanistic study.
But also
100 lesions.
Important point from that study is that when we don't have TICFA, we don't have lipid-rich plaque, we are safe.
Exactly.
There's no adverse events during the long-term follow-up. We can also understand that, in my opinion, that papers from the other side that patients.
So now I will do a CT to every patient with apparently normal coronary arteries.
No, that's not a good message. You would overstand too many of them.
No.
But you know, CLIMA study is an important study, but it's a registry. Okay, it's a comparison in a single registry. We also gave some patients to that study from Fattebene Fratelli, if I remember well. I don't remember if it was CLIMA or the other one, but we gave some patients. It's not a randomized study. Okay, it's not a prospective study. It's prospective in the sense that data have been analyzed prospectively, but centers used to send images with an Excel sheet. That's the major limitation of that study, which is a good study, but it's not a definite study. We need to have a prospectively designed study, randomized with 2 strategies or treatment options before having, in my opinion, a good answer to this question. Other points, comments? If not, I think we can stop here recording. Thank you, Wojciech.
Thank you.
Nice.